Hello, everybody, and welcome to today's podcast. I'm Dr. Christine Glue, and I'm one of the advisors as a GP at the Wessex Cancer Alliance. And I'm delighted to be joined today by two members of a charity called Lobular Breast Cancer UK. That's Fiona and Claire. I was delighted to meet Fiona at our Wessex Cancer Alliance conference where she was running a stand, and we had a really interesting conversation, which I know she had with a lot of the attendees. And as a result of that conversation, I really wanted to record this webinar for you to have a chance to hear some more information than you might already know about this type of breast cancer, because I think it's really important for us in primary care to be aware of some of the differences and some of the new thinking about lobular breast cancer. I'm going to hand over now to each of our participants, and they're going to introduce themselves for us and tell us how they came to work for the charity.
Hi, I'm Claire Turner. I'm the Interim Chief Executive of Lobular Breast Cancer UK. I'm one of the founder members. I got involved because I had a lobular diagnosis back in 2017, which took about 7 years to get diagnosed, which we'll be talking a bit more about that later on in the podcast. And it was kind of my idea to get the charity set up, and I worked with a group of the women who'd also had a lobular diagnosis to set up Lobular Breast Cancer UK.
Hi, I'm Fiona Baber. I was a full-time GP principal in Southampton when I got the diagnosis of lobular breast cancer. I had never heard of lobular breast cancer before and started to want to know more about it. In that process, I actually applied for a position on Breast Cancer Now Scientific Strategy Board, and I'm one of two patient advocates on that board that looks into research that's going ahead in breast cancer. And when I joined, there was very little research into lobular. And being part of that, part of Breast Cancer Now, I was invited to a breast cancer multidisciplinary symposium in Birmingham 3 years ago. And at that symposium, Claire had a stand, and it was the first time I had met anyone else who was talking about lobular breast cancer, and we got talking, and since that I've joined the group, and I'm now part of their GP working group, trying to increase the knowledge and research in breast cancer and getting it seen as a distinct disease.
Thank you both. That's really interesting to hear how you met and what you're trying to achieve. My first question is, as you reflected, Fiona, about many healthcare professionals not necessarily being familiar with this type of breast cancer. Could you start by telling us what it is and who LBC UK are?
Sure. So lobular breast cancer is actually, even though, as we've said, is kind of maybe not known by many GPs or have really heard about, it's actually the second most prevalent type of breast cancer. I think one of the things that is really important that everybody understands, primary care, secondary care, the public, is that breast cancer, there isn't just one thing that's breast cancer. We all think, oh, there's breast cancer and that's what everybody gets. But actually there are different subtypes of lobular, inflammatory, triple negative. So, and lobular is, as I said, the second most prevalent type. It's about 15% of all diagnoses, and we've just got the first annual data from NHS England, which confirms that, roughly about 15% in England, which equates, and when we kind of equate the data across the whole of the UK, it's roughly about 22 women a day are being diagnosed with this type of breast cancer. It has for many years been, people may say it's rare, but actually you're talking over 8,500 women being diagnosed each year. So it's actually the sixth most prevalent type of cancer in women. So we're rare in comparison to the overall population of breast cancer, but in relation, when you compare it with other types of cancer, it's not. And at Lobular Breast Cancer UK, because when we hear that primary care professionals have not heard about it, as patients, the first time we ever hear about it is when somebody says, oh, you've got lobular breast cancer. And we hear lots of stories of patients Googling, which I know we often are told don't Google, but we do, Googling ovular and globular, and because we've never heard of it. So not only are we dealing with the trauma of we've had breast cancer, but we're also dealing with this new type we've never heard about. And so at Lobular Breast Cancer, we're 100% led by women who've had a lobular diagnosis. And one of our key aims is raising understanding, raising knowledge, increasing education around lobular breast cancer. And that's how we work within the charity to, really raise that knowledge and understanding about lobular.
Okay, thank you. And Fiona, can I come to you and ask you why it's harder to diagnose women with lobular breast cancer?
Yes, lobular breast cancer lacks something called E-cadherin, which is almost like an adhesive. So in other forms of breast cancer, that will stick the cancer cells together and they will form a lump. But with lobular, that doesn't happen. So it tends to spread through the breast like a spider. So that usually, the thing you're only aware of is perhaps a thickening. There are other symptoms that can go with it, but it's initially just a thickening and not a lump. And the thickening is often not felt by other clinical people, as is with my case, it was only me who could feel it.
Okay, that's really interesting, isn't it? And expanding on that, can you explain about your experience to diagnosis and
Yeah.
what that felt like and how long that took?
Yes, I probably was experiencing the thickening for about 3 months or more before I approached someone. My husband couldn't feel it. I actually found it quite hard as a GP because I felt a bit stupid about going along to a GP with something that nobody else could feel. And I did present to him and he couldn't feel it. And I have no qualms about that because that's the nature of the disease. So he recommended I came back in a month or two if I was still worried. Um, I actually chose to take myself privately a month later and had a mammogram in my lunch break from being a GP, which they came through and said was totally normal. Why was I there? Did I have a lump? And I said, no, I haven't got a lump, but it just feels different. And very gratefully, Dr. Rubin at Southampton ultrasound me and thought that there was probably something on the ultrasound scan and did 4 biopsies, all of which were positive, but absolutely nothing on the mammogram. And when I saw my consultant later, he couldn't feel it and admitted he would never have found it. So it's very difficult disease for clinicians to diagnose. The MRI I then later had did show it partially, but that wasn't fully, and I ended up having an incomplete wide excision and going on to have a mastectomy.
Oh, thank you. I mean, that's, as a medical professional, that's such an interesting experience, isn't it? It's sort of, it's terrifying from a personal and a professional point of view, isn't it?
It is. And I think because I was so aware of my own body and was able to know the pathways through, but I think if you're a non-medical clinician, it must be a nightmare because you do feel like you're wasting their time. That's what I felt like. They were not that that was how they were making me feel, but that's how I felt.
Yeah. And if we could turn to you, Claire, what was your experience of diagnosis?
So I first went to my GP, it was kind of 2012, and I didn't even have a thickening. I just had something just feels really weird. And I got my GP's amazing and just trusted what I was saying. I was saying there's definitely not, there's something wrong. And it actually took me from that first visit in 2012, it took me 7 years to actually get diagnosed. And because I was sent to the breast clinic each time, my GP was wonderful, believed what I said, sent me to the breast clinic. But I kept having mammograms. I mean, I've lost count of the number of mammograms, ultrasounds, biopsies I had, all came back clear. In 2014, I was diagnosed with what is called pleomorphic lobular carcinoma in situ, which is a marker for increased risk, but not an actual cancer. We do know now that if someone has that diagnosis, in the majority of cases, invasive disease is there in the breast. So it's kind of important to GPs just to think, if I hear, oh, somebody's had that even if the mammogram's clear, there might be something else that wasn't known at the time. This was 2014.
Yeah.
So I had a lumpectomy to excise that, but then I was on annual mammograms. I continually, in that 4-year period, 3 year period from then until I was actually diagnosed, I went back. I had at least 7 or 8 mammograms. I was going in between my mammograms saying there's something really not right. I was starting to get the thickening, as Fiona described. I was getting tugging sensations in my breast. I was getting stabbing pains. And then I went a month before my next annual mammogram, and it looked like somebody karate chopped my breast and it had not gone out, saying there must be, you can't tell me there's not something wrong. And the mammogram came back for the first time ever showing 8 millimeters of invasive tumor. But when I actually had my mastectomy, there was actually 8 centimeters plus. It was throughout my whole breast. It had clearly been there a long time. And that kind of really blew my mind. But the one thing I do want to say is my GP every time really listened, really trusted me. And I think that's a real challenge for women, to keep trusting yourself and trusting your body when you know that there's something wrong and you know something's different from how things feel for you. And GPs really listening to women when we're kind of presenting with that is so important.
Yeah, thank you both. I mean, I know those are both very personal stories to share and very difficult stories to share. It is obviously comforting to hear that you both were listened to by health professionals, and that the health professionals shared some of the dilemma and some of the concerns that you have. I know, having spoken to radiologists in the past, they also have a concern about this, don't they?
Yeah.
Sorry, carry on.
Yeah, absolutely. And I think that's one of the things that is really important, that the knowledge is growing, and we know change needs to happen, but we know to change the guidelines, you need that, not just one piece of evidence and one piece of research, you need that repeated, replicable research. So I think there's this growing awareness, both in primary and secondary care, that we need to change this. And that's kind of one of the challenges that we're working at with LBC UK. So
yeah, and that's brilliant to hear. I think the other thing that really resonated in what I was hearing there was that you both had to advocate for yourself.
Yes.
And that's really important, isn't it, for women? It's important for all patients, but it's important in this scenario particularly.
And I think we've done a GP survey at Lobular Breast Cancer UK asking patients what their experience was with GPs for both primary and metastatic disease. And what was great to see was the feedback from GPs when people are presenting prior to a primary diagnosis with symptoms. There was response from GPs was fantastic, sending them to the breast clinic, making sure people got checked. But it's also, I think, recognizing that if you are repeatedly having to self-advocate, it's actually quite exhausting for you. And and as Fiona said, kind of, you think, it's challenging because you think you're being a nuisance and you think you're wasting resource. Yeah. And so I think there's that recognition of the psychological impact of a lobular diagnosis can have on a patient, both pre-diagnosis and then post-diagnosis as well.
And I think we do need to remember, don't we, that not every patient can advocate for themselves in exactly the same way as you two both did. And that's really important for clinicians to be aware of, isn't it?
Yeah. Yes, and I think also very important, as Claire has mentioned, is that often you are told after your MRI that it is this size and quite small, but in fact, when you come to surgery and it's taken out, the tumour is often much bigger than they expected, and that is quite scary, that something can be there and you're not aware of and doesn't show up on any imaging.
Fiona, I was wondering whether I could come to you and just ask you a question that we covered when we met at the conference. Does lobular breast cancer present as breast pain alone?
I think it is unusual for it to present as breast pain alone. Most people will have the other symptoms, the thickening, etc. And I also think it is a different pain. The strands sort of pulling, it's a tugging sensation. And certainly just before I had my surgery, I had some dimpling and pulled her on. So it's more to do with that than a sharp pain that perhaps might go with costochondral pain or something like that. So it may be part of it. I think it's unusual for it to be the symptom alone.
Excellent, thank you. That's really reassuring. Claire, can I just ask you around some of the myths that might be associated with lobular breast cancer and whether you could potentially debunk some of them for us?
Yeah, I mean, the big one is lobular starts in the lobules, and you'll see most of the most of the cancer organizations say it, most of the top clinical organizations say it. If you kind of get involved with lobular researchers and clinicians who are researching lobular, actually it was seen in the lobules for the first time. It was discovered in the 1940s, and that's where it was seen. And so it kind of got named lobular breast cancer. But actually, the research we know now is there's no real evidence that it starts in the lobules at all. And men don't have lobules, but men, whilst very rare, it's about 8 men get lobular breast cancer in the UK every year. Whilst men don't have lobules, they can also get lobular breast cancer. So that's the big one, but we're really struggling getting anyone to change that. Other classic ones, chemotherapy doesn't work because lobular is predominantly, not always, quite slow growing, and obviously chemotherapy targets rapidly changing cells. Chemotherapy doesn't work for a lot of people with lobular, but actually lobular isn't just one type of disease. To make it more complicated, there's about 7 different types of lobular. Chemotherapy can be incredibly effective and for some people with lobular. And I think that's the other thing that's really important for GPs to say to patients. Share, don't compare with somebody else who you meet with lobular, because we're all different and you may have a different treatment. It doesn't mean they've had the right treatment and you haven't. It's because there's kind of different types of lobular. Then we've touched on before, the treatments don't work because they're not specific to lobular. There's real evidence that shows that the treatments can be incredibly effective for lobular. So, we don't want people panicking that because it's not a specific lobular treatment, it doesn't work for them. You may hear that lobular is more likely to be bilateral. So that was the evidence initially. People thought we were much more likely to have it in both breasts, but the research is showing that actually it's only very slight increase of the chance of bilateral, because you may have patients coming to GPs saying, I want a bilateral mastectomy because I'm worried about it. It's more likely to be in the other breast. And I think there's another one which I've got this at LBC UK. We're really trying to change the semantics around lobular. So they might have patients come in and saying, oh, it's we've actually had clinicians telling patients it's the sneaky one. It's this, oh, that's the sneaky one type of breast cancer. It's like, how much more do you want to scare people by giving it a name? And the key thing is it's not sneaky. We just don't have the right tools to diagnose it, or the most effective tools to diagnose it at the moment. And as soon as we do, it's not going to be sneaky anymore. So let's not call it sneaky. It's not creeping around. It's not like, oh, it's mammogram day, I'm going to go and hide somewhere else. So I think it's, we need to, GPs can really help patients to change the language they're using around it. So if they hear them saying sneaky, maybe just that, oh, I don't, clinically, it's not really sneaky. It's not hiding. And it just, there's research has shown the language we use as patients, even if we're not aware of it, actually heightens our anxiety about the disease we have. So those are kind of some of the great things I'd love to kind of myth bust about lobular.
Thank you. That's really interesting. Can I take you on now and ask you a question about the differences potentially when it comes to treatment in lobular breast cancer, and also the differences in metastatic recurrence?
I mean, at the moment, because lobular within the NICE and SIGN guidelines isn't recognised as a distinct disease, It's one of the campaigns we've got at Lobular Breast Cancer UK, distinctly lobular, to really change that, because it's not recognised. We get treated the same as ductal breast cancer. And I think the really important thing for GPs to be able to reassure their patients with is, just because a treatment is non-specific for lobular, it doesn't mean it's not effective. So there are differences, and the research is showing that, for example, chemotherapy is not as effective for lobular, but it can be really effective for patients. And that's a really important message, because there's lots of myths out there about lobular, that chemotherapy doesn't work, that none of the treatments are specific, so they don't work. Actually, the research has hormone therapy that the majority of lobular patients on is incredibly effective for lobular. CDK4/6 inhibitors, which are quite new, so GPs might have some patients. Obviously, it stops the protein that prevents the tumours from growing, potentially metastasizing. They've been shown, there's actually a study at San Antonio Breast Cancer Symposium in December, the world's largest breast cancer symposium, that showed that CDK4/6 inhibitors in both primary and metastatic disease can be more beneficial in lobular from ductal. So I think the key thing for GPs, the message that I've suggested as patients is, one, non-specific doesn't mean non-effective. A lot of the research is showing the treatments we have, because we have, in the majority of cases, we have hormone positive disease, and that's what the treatments are treating, your treatment is really effective. And some of the new treatments are really effective as well. Doesn't mean we don't need more research and understanding. Doesn't mean we can't go, there's some really exciting research that came out about, I think, something called LOX inhibitors that are linked with collagen that lobular makes, because it doesn't have this, to create its own little world, because it doesn't have the solid tumor. So that potentially could be a really exciting target. So it doesn't mean we can't look for specific targeted treatments. But I think the key message for GPs is the treatments we're having, whilst not specific, can be incredibly effective for lobular.
Okay, thank you. I mean, that is encouraging, isn't it?
Yeah.
And then if we move on to another topic that's very close to the heart of GPs, particularly with the onset of patient-initiated follow-up, so patients coming back to us potentially with a recurrence. Can you explain to us how lobular may present differently at that stage, and both of your experiences of that potentially?
I think I'm happy to say, I mean, it does spread like other breast cancers to the bone and the liver, but it also spreads commonly or to more unusual places: the gastrointestinal tract, the stomach, the ovary, the peritoneal lining, the pleural lining, the leptomeninges, anything that can go along, and its spider pattern, it can creep along it, and also the eye. So someone presenting, like I actually did to my GP a few years ago, with stomach pain, they need to be able to, we're trying to get that it's read coded properly, and that perhaps a warning will come up GPs and saying, this person's had lobular, this can metastasize the stomach, be aware of this. It's very important that people are aware of the different metastatic spread. And also the thing with lobular is it also can occur many, many years later, over 10, over 15, over 20 years later.
That's interesting.
As are a lot of hormone positive receptor tumours, but particularly lobular, can be very late in presentation. So this lady may have had breast cancer 20 years ago, and I was 49 when I got it. 69 is not that old. I'm not there yet, but I hope that people have got to remember that this kind of been many, many years ago, and don't assume because it was 20 years ago, that's not it.
Okay, I think thank you. That's really interesting.
Yeah, and one of the things that did come up, obviously, I mentioned the GP survey we did before, and patients felt really, they were really confident in terms of how their GP worked with them when they presented for a primary diagnosis. That unfortunately slightly changed when it came to patients presenting with fear of recurrence or a metastatic diagnosis, and particularly for those patients who were diagnosed with metastatic disease. In primary, it was, you went to your GP, you said you've got concerns, you went straight to the breast clinic. Often with metastatic disease, it was potentially multiple GP appointments you had to have, sometimes with different GPs, and also it could take a while before it was recognized that actually this symptom, as Fiona was saying, it could be a GI tract symptom, it could be ovaries. This symptom, or a head, one of a member of our GP working group, who's actually a practice nurse, was told when she went for concerns about a headache recently that, oh no, it doesn't go to the leptomeninges, don't worry about that.
But she knew it did.
She knew it did. And interestingly, what you were saying, I think, Christine, which is really important, saying about me and Fiona, we could advocate for herself. She's a really strong, powerful woman, practice nurse. And she just went, I was just exhausted. And I thought, I can't even be bothered to argue. I'll go and see somebody else because I don't want to have to get into. And so even sometimes, when we've come through a whole diagnosis and the stress of that, and you faced with a clinician who just says, no, you're wrong. You just think, well, I'll go to somebody else. So I think we need to do better when it comes to that recognition and diagnosis of metastatic disease, which kind of the point that Fiona mentioned about coding could really help, because we recognize as GPs you can't know everything. So actually, can we help you to change your systems so your systems give you the warning and go, actually, have you thought of this? Yeah. And I think the really important thing as well to tell patients is one of the other myths you hear is everybody metastasizes eventually with a lobular, and that more people metastasize, which obviously is, I suppose, aligns with everybody. That isn't the case at all. The data at the moment shows it's roughly about a third of people who've had a breast cancer diagnosis, same as in ductal breast cancer, progress to metastatic disease. So I think that's another thing that's really important, saying, we get a lot of people really worried about recurrence, and they go, oh, I'm going to be one of the people that get metastasizes, and we have to say, no, flip it. The majority of us never metastasize. And we're all different. And the stats are stats. You're not a statistic. So that's, I think, a really important message for GPs when they've got a patient with a concern. Listen to their concern, obviously, and kind of look at referring them as quickly to the right place as possible. But I think it's that, and really knocking that myth that we're all going to die of lobular, which isn't the case at all.
No. So what I've heard from you today, and thank you for sharing your experience, is that lobular breast cancer is quite common. It accounts for 15% of all breast cancers, that it is treatable, and the treatments can be as effective as they are for any other type of breast cancer. That as GPs, we should be wary about the pitfalls in diagnosing it, as well as secondary care being aware of those things. That we should have the same threshold of concern about patients presenting as possible metastatic cases, but you might present much later than other cancers and other types of breast cancer. And that you, I think, are a very research and evidence-based charity. So I don't know whether you want to just summarise for us what you would like us to have heard as your main messaging, and then just talk a little bit about what your hopes are for the future years.
Yeah, I mean, I think the key things that we'd love GPs to kind of be active in and support the patients with. The first one is coding. We know there is a code for lobular, but we know that few GP practices are coding for lobular. It's kind of, we get put in as breast cancer. And it would be fantastic if GP practice could start coding, because then we can start looking at a way to develop systems that automatically flag you warnings, give you information that a patient's had lobular, rather than relying on you to remember everything about every subtype of breast cancer. So coding would be brilliant. I think a key thing is recognizing that not all breast cancers have a lump. So when patients present, listen to the other symptoms that might be thickening, that might be tugging sensations, that might be stabbing pains, that might be itching, that might be indentations, and encouraging your patients, if they do come to you with breast cancer concerns, to think when they are self-examining that it's a look and feel, and it's that importance of what's different for you, what might have changed that isn't around how your body normally feels. A real awareness around the difficulty of diagnosis, as you mentioned, Christine, both in primary and metastatic disease, and just that awareness of the different ways people might present with concerns about lobular. Recognizing, particularly when people have already had a diagnosis, some of that psychological impact of that concern about recurrence is big within lobular patients. And at LBC UK, we've done research with psycho-oncologists and health psychologists on that, and we have seen there's a real psychological impact of a lobular diagnosis on patients. So recognizing that might be an issue that patients are coming to you with, that follow-on psychological poor health from diagnosis, and also that reassuring patients that the treatments they are on, whilst not specific, can be incredibly effective for lobular as well. And yes, we are looking at more research, and more research is happening to identify targeted treatments, but don't stop your tablets, or don't stop what treatment you're on because you think you've heard somewhere that it's not specific for lobular, so it doesn't work. So I think really key ways that GPs can simply support patients.
Thank you. That's brilliant. Did you want to talk in any more detail about some of the projects that you're looking at over the next few years?
Yeah, I mean, the key things, I'm really pleased to see that you recognise we're very much research evidence based, and the three pillars of what we do at LBC UK is that support for patients. So again, GPs can send patients our way. We can provide them. We have meetups. We can provide them with information to have conversations with our clinical team, send them information about lobular if they need it. But we also do a lot of research. We work with researchers, and I think that is important for GPs to know as well. There's a really committed and collaborative research network here in the UK and overseas. So we do a lot of research. And then a key thing, I think, which links into one of the things we're doing, is we've got a campaign called Distinctly Lobular. And it kind of pulls everything we do together. And as I said before, the guidelines don't recognise lobular as a distinct disease. And our Distinctly Lobular campaign is working to get that change within the clinical guidance for how lobular is treated. And alongside that, we've just launched, and Fiona's actually on the steering group representing primary care. We've just launched a James Lind Alliance priority setting partnership. James Lind Alliance priority setting partnerships, for those that have not heard of them, it's a framework developed by the National Institute for Health and Care Research, and their aim is to look at, within specific diseases, not just breast cancer or cancer, it's all diseases, and it brings clinicians and patients together to look at what are the key questions we need to answer with research for this specific disease, so we can enhance and change clinical practice. And we're doing the first ever one for lobular breast cancer, so we can work towards that guidelines change. And we're going to be sending a survey out, which we would love any GP, any practice nurse, any primary care clinician to fill in.
Okay.
And then because what we do is we come up with a top 10 of research questions that we need, which will then help towards that change in clinical practice. And we also will be having, in about 12 months, a day where we bring together clinicians and patients who are not on the steering group to help decide that top 10. So if there are any GPs out there who fancy getting involved and helping us to change clinical practice, there'll be a call out for that as well. So that's kind of the real focus that we're working at LBC UK at the moment, to make that real change happen at the clinical end for anyone diagnosed with lobular.
That's brilliant. Thank you. So the links to all of the information that Claire's referencing there will be on a slide at the end of this webinar. There's obviously the LBC UK website where some of the information will also be available. If I could point you to the primary care single A4 information sheet. Certainly Fiona gave it to me and a lot of participants at the conference, and it's a really good summary of what we talked about today. It would be brilliant for a 5-minute piece of education. It would be great if you could talk about it in your practices and share this knowledge with other people, or invite them to, watch this webinar. Obviously, it'd be great as a group of practice nurses or advanced practitioners to have a look at this. It will be available on the Wessex Cancer Alliance website in the primary care site, and I think it will also be available on LBC UK, won't it?
Yeah, and we've got as well, we've been piloting them, and we're hoping that we'll soon have enough to start sending out to GP practices. So we've got, I don't know if you can see actually, a little box that within the little box, we pinched the idea off prostate cancer. Actually, I saw it in a GP practice. I saw it in GP practice and thought we need a little bit of that. And within each box are these little cards, which I don't know if you can see with the provides information about Lobular. We'll be having these available soon if GP practices are interested in kind of just putting them out as bits of information. I think because the one thing that would really help is often when you're diagnosed with lobular breast cancer, you don't get given any information that's specific to lobular. So you kind of go away, and that's why we end up Googling. So it'd be great if GP practices can help to share that information, both to their kind of the wider patients, but also for patients who've had a diagnosis. So they will be there as a resource for patients as well, that we're aiming to get out into GP practices.
That's fantastic. Thank you, both of you, for sharing your stories and for such brilliant piece of education today. We really do appreciate it, and we would, as the Alliance, like to help you in future. So yes, if you need our help to share the GP surveys and things like that, would be really welcome.
That's brilliant, and thank you so much for you as well. I mean, it's this collaborative work with patients, clinicians, researchers that's really going to make the change for anybody who's been diagnosed with lobular. So thank you so much for inviting us and enabling us to talk about it today.
No problem at all.
Thank you.